Next, we're going to talk about adverse reactions to gadolinium-based contrast. This information comes from the American College of Radiology and their manual on contrast safety. I strongly encourage you to look it up and review it. Serum calcium levels. First of all, there are some contrast agents that do interfere with serum calcium levels. The package insert will tell you that if you have a MRI with contrast, you have gadolinium in your bloodstream, and then you have a serum calcium level lab test done, it will give you a false positive reading for up to 24 hours. What this means to you as a technologist is before you inject any type of contrast, you should take time to open the package insert, read it from front to back, and know what the contraindications are before using it. Now, talking about off-label use, MR contrast, if you read the package insert, the contrast is usually has been FDA cleared for certain types of procedures in certain age categories. But even though the contrast label or the insert does not say things like pediatric under the age of 2, breast MRIs, body MRI, or angiography, you will find it is common practice throughout the country, throughout the world, to use this contrast even in those types of exams. Even though children do tend to have less reactions than adults, MR contrast is not indicated for children under the age of 2. But the reactions, if they do have one, are just the same as adults. Minor reactions would be hives, rhinorrhea, sneezing. Severe reactions, bronchospasm, laryngeal edema, shock, cardiac arrest. They're just as severe. Now, administering contrast to a mother who's breastfeeding a child, less than 1% of what you give the mother through IV is excreted into the breast milk. And so we typically give instructions to discard breast milk for 24 hours just to make sure that that period of time is elapsed. Less than 1% of the contrast medium that actually does make it into the breast milk is passed into the infant during breastfeeding. So it puts the infant dose to be extremely minimal, but that dose recirculates throughout pregnancy, so it's important to follow your department policies and procedures on how to handle the situation. So let's talk about how does this gadolinium get out of your system, or how fast it does. Gadolinium clearance. 50% of the IV medicine you give them will be excreted out of the urine in 2 hours. There's a half-life process, so 2 hours after that, another half of the gadolinium is left will be excreted. 2 hours after that, another half is gone. And it's completely or nearly completely excreted within or after 24 hours. And finally, we're going to talk about a disease called nephrogenic systemic fibrosis, NSF. This is a life-threatening disease that has been directly linked to the administration of gadolinium in high-risk patients. The best defense against a patient getting NSF is the technologist. What you're looking at here is an image of a patient who has NSF. NSF typically will appear on the periphery of an extremity, so distal hand, distal feet, lower legs. What it looks like, it almost looks like a very bad cellulite. It's red, it's swelling, it's warm to the touch. And what it is the iron component of the gadolinium has unbound from its chelate molecules. And so it is free flow, it's free iron that has accumulated in the tissues of the patient. And yes, I am saying iron. So how do you avoid giving a patient NSF? This is a suggested protocol that Dr. Emmanuel Canal, he is a world-renowned expert in MRI safety, and he works out of the University of Pittsburgh, has recommended. The patient who's at risk are those who have a history of renal failure. They are either currently in renal failure or even a dialysis patient. For these patients, we should try to avoid giving them gadolinium if at all possible. If not, take a T1 fat-suppressed axial before giving the contrast so you have documentation of what the tissue looks like. And this is of the lower extremities. Then use a half dose of gadolinium if at all possible. A full dose if necessary, but absolutely never double dose. That's that 0.2 mmol per kilogram. Never double dose, or per pound. Never double dose a patient who is at risk for NSF. Then do the exam. After the exam, take another T1 fat-sat axials immediately after the contrast has been given. Then bring the patient back a week later and again take T1 fat-suppressed axials. If the patient is already on dialysis, dialysis should be done immediately after the contrast was given. And I don't mean immediately after, not 24 hours later. I mean get off the table, go get plugged into a dialysis machine. That's how serious it is. So besides just asking the patient, have you ever had kidney problems in the past? Are you currently on dialysis? The other clearance mechanism for protecting the patient from NSF is checking their lab values, getting a BUN and creatinine beforehand. MRI is now going to something called eGFRs, estimated glomerular filtration rates versus just straight creatinine levels. So what you do is you can use a tool similar to the DaVita.com calculator. You plug in the patient's age, weight, sex, origin, and their creatinine levels, and it will calculate for you what stage of glomerular filtration rate the patient is at. The stages go from stage 1 to stage 5. Stage 1 and 2, pretty much you have healthy kidneys. Stage 3, you're a little at risk. Stage 4 and 5, you're in danger. So what do? Follow your department's protocol. Ask what your department protocol is for creatinine levels. Do you use creatinines or do you use eGFRs? Any person during the clearance criteria, when you're doing the interview, that exhibits either the history of chronic kidney disease, dialysis, or is at a certain age. A lot of facilities use age 50 or over, 55 or older, 60 or older. They will require a creatinine be done prior to the exam being performed if it's going to involve contrast. Is that enough for your department? Do they require an estimated GFR to be calculated? This is not like CT contrast. It's not like X-ray contrast where, oops, I gave the contrast to someone who has bad kidneys. Let me just schedule a dialysis the next day and they'll be good. Once you've given this contrast to someone at risk, it is done. Dialysis is not a fail-safe. We do not know that dialysis will work. In fact, current studies have been inconclusive to see if dialysis immediately after getting the contrast has any effect on the risk factors for NSF. This is just like MRI safety when you have to clear the patient before they go into the room. There are no do-overs. One chance. Once the contrast is administered, that's it. It's done. You have to deal with the consequences afterwards.